Welcome, everyone. We're thrilled that you're able to join us for our webinar today. So the focus is perinatal borderline personality disorder. So my name is Christina Canton, and I'm a perinatal consultant with the Champlain Maternal Newborn Regional Program, or CMNRP. And I'm also a fourth-year PhD in nursing student at Queen's University. So the CMNRP is a regional program whose goal is to improve perinatal and newborn care in Ontario Health East. And CMNRP's goal is to ensure high quality integrated services and care at the right time, at the right place, by the right provider along the continuum of care from pregnancy through the postnatal period. And I want to first acknowledge that the land on which many of us are meeting today is the traditional territory of the Algonquin Anishinaabe Nation, which is home to many First Nations, Inuit, and Métis peoples. We recognize the Indigenous practices of health and well-being have been in place since time began and are maintained to this day. And there's still much work to be done to honor Indigenous women and families' pregnancy journeys and to bring reconciliation to healthcare in this region. And so I invite us to move forward together with kindness, with humility, and with respect. On the screen, you'll see that this month is Indigenous History Month. And this past Friday on June 21st was National Indigenous Peoples Day. There's beautiful imagery and symbols. The eagle represents First Nations, the narwhal representing the Inuit, and a violin representing the Métis. And so these illustrations are placed around the sun and surrounded by multicolored smoke, which represents Indigenous traditions, spirituality, inclusion, and diversity of all First Nations, Inuit, Métis communities and their members. And it's really interesting to know that smoke is used in different ways by all three Indigenous groups in Canada. So whether it's smoke fish and meat, or to burn sage and tobacco, or for sacred ceremonies or celebrations, it's a significant symbol in Indigenous culture. So hopefully you've had a chance to join in some of the events that have been happening this month. In terms of a few housekeeping details, the webinar is being recorded and will be posted on the CMNRP website within about 2 weeks or so. Throughout the webinar, we encourage you to use the Q&A button to add your comments or questions. This allows us to help determine how much time to leave at the end for discussion. And for the next slide, we want to ask who here is with us today. So we have a couple poll questions. It's going to launch now in terms of your profession. So we'll give you a minute to just complete that if you're able to. And so it looks like we have about 2/3 of the group are nurses, and we have social workers, physician, nurse practitioner. So we have a real mix of people here today, which is wonderful. And for our next poll, we just want to assess, before we get started on the webinar, the level of knowledge about perinatal borderline personality disorders, and then your level of confidence in terms of identifying the clinical presentation and supporting your patients or clients. And we're just going to give that a minute. People are pretty fast on these poll questions. It's really fun. It's helpful when we do the polls to kind of get a sense of where everyone's at. So in terms of the level of knowledge, it looks like about 2/3 of the group is somewhat knowledgeable, and we have about 30% who are not at all knowledgeable. In terms of confidence, it's split in terms of somewhat confident in terms of identifying the clinical presentation of perinatal borderline personality disorder, or not at all confident. And then in terms of supporting patients, about 65% are somewhat confident, and 30% are not at all confident in supporting their clients. So I think this is going to be a really important webinar for all of us to learn about today. Okay, so let's go to the next slide. Without further ado, I want to introduce you to Dr. Valérie Giroux. She is a physician who did her training at the doctorate in medicine at McGill University. She did her residency in psychiatry at Laval University and a fellowship at Western University in maternal mental health. She has worked at the Multhorpe Hospital since 2016 as a perinatal psychiatrist and in the service of borderline personality disorder since 2022. She's also the inaugural chair or co-chair of the CMNRP Perinatal Mental Health Community of Practice. And she's originally from Quebec City. So welcome, Valerie, and thank you so much.
It's a pleasure today to speak to you about perinatal borderline personality disorder. When I did my first rotation in perinatal psychiatry. I was very surprised and also intrigued why mothers with BPD did not have much services. It was often in a lot of services that I saw in perinatal psychiatry, it was a criteria of exclusion. And to me, it did not make sense because I thought like they probably struggle a lot in their parenting and also to build attachment relationship with their child. And so, and I always liked to work with patients with borderline personality disorder. That's why I joined the BPD clinic at Montfort in 2022. And the same year, I started groups for people with for mothers with borderline personality disorder. So let's start. If we look at the beautiful perinatal mental health framework that we did at the CMNRP of perinatal mental health, I think that perinatal, I'm just gonna change a bit here so that we're able to see everything on the slides. So I think that the perinatal BPD services fall into the Pentagon 6 specialist consultation and care. So today, the objective will be to know a bit more about what is borderline personality disorder and how the symptoms affect parenting. So we're going to look at the criteria and how those criteria goes into parenting. Then we're going to look at the prevalence of borderline personality disorder during the perinatal period. We're going to look at the clinical presentation that we expect to see during pregnancy and the first 2 years of life. What have been called the 1,000 first days, which are so important in the development of the attachment relationship, but also for the development of the child. We're going to look at what are the potential impact of BPD on the mother and child relationship, as well as on the child development. And finally, I'm going to share to you a longitudinal study that I started with a team of research on mothers with BPD and their children during pregnancy up to 6 years of age of the children. So as discussed previously, there is not much services offered for mothers with BPD. And in terms of literature, in terms of research, there's not a lot of studies. If we look instead at the study for depression, anxiety disorder, and bipolar disorder, there's much more literature for those subjects. And if we come back at the article for mothers with BPD, during the peripartum period, those studies are usually limited in terms of the number of time they look at the period of time, but they also look at data from the past, which is a certain limitation of those studies. If we look at what PubMed said, so for perinatal depression, we've got around 6,000, more than 6,000 articles. If we look at perinatal anxiety disorder, sorry again, there is around 1,600, and bipolar disorder, more than 300, and then perinatal borderline personality disorder, less than 50. So little amount of articles. Now we're going to look at what is borderline personality disorder. So first of all, personality disorder, it needs to, someone needs to have the symptoms throughout the lifetime. And these needs, so not only like at certain period of time, so when there's stressors, if it's the case, if their symptoms only appear when they have stressor, it's called treats instead of disorder. It needs also to be present in most relationship in their lives. We say with personality disorder, it's hard to love and it's hard to keep working as well, to keep a stable job, because those traits or those symptoms are so present and invasive. And it's also not, it's not caused by a medical condition or by another psychiatric disorder. So for borderline personality disorder, according to the DSM-5, we need 5 out of 9, criteria. If we look now at each criteria and then look what it kind of show in parenting. So the first one being a lot of insecurity in a relationship with others, with fear of being abandoned and rejected, and some effort to avoid that. Then it will present in the relationship with their child as difficulty when there's any step of autonomy, with some behavior to avoid that. And then in the second criteria being a pattern of unstable relationship with others, with a lot of idealization and devaluation, enunciation of those, which is going to be really difficult to follow for children, which is going to be unpredictable, unstable, very different interaction in time, and also different expectation and inconsistent discipline as well. Sometimes very harsh and strict, and sometimes very lax. And then the third criteria, some disturbance in identity, which for the mother will mean that like sometimes having a very positive, sometimes very negative variation in those way of seeing themselves as a mother, which then will be very confusing for the child and also affect their own development of their image as a children, more negative, and will be more negative. And then the impulsivity, this will make the child being in an environment that will be more risky and feeling unsafe. We look now at the recurrent suicidal behavior and self-harming, same thing, will be very feeling unsafe and unpredictable for the child, and maybe frightening as well. Same thing for the roller coaster of emotion that will happen within the same day. For the 7 criteria, the chronic feeling of emptiness, the risk of, so it means that the person will feel always empty inside. And that can be present more at certain period of time as well. And what in relationship with the child, there is a risk that the child become the object, feeling the void that the parent has. And then the 2 last one, the inappropriate anger and the dissociative symptoms and psychotic symptoms at times will also make the environment with which the child grow very unstable, unsafe, and confusing. There is a very good article which describes those criteria and the effect of parenting that you can read. Now, looking at the prevalence of borderline personality disorder in the general population. So BPD, borderline personality disorder in general population, it's about 1 to 2%. If we look in psychiatric facility, we see about like 50% of people with borderline personality disorder. If we now look in perinatal mental health clinic, we see a prevalence of 14%. That's with a recent meta-analysis done in 2022. If we look now at the prevalence of perinatal depression worldwide, so perinatal meaning like during pregnancy and postpartum, worldwide, it's 11.9%. So we see we have a relatively high prevalence of perinatal BPD. One of the first person who noticed that the mothers with BPD struggle is Ansped William, who works in Australia, who started seeing that those moms are very distressed by their parenting role. She started seeing that around 40 years ago. And so she started to look at in mother and baby unit that she was working, that there's a lot of proportion of mothers who have BPD and BPD treats. And these seems also to often come with, as a first presentation, with postpartum depression. And it seems that their postpartum depression is different from the one without the treats or the disorder. They seem to exhibit more severe symptoms, more distress, more difficulty adapting to this role, as well as a persistence of symptoms over time as compared to mothers without the disorder. And so she decided to look at the numbers. So she decided to make a study and looking at how many people have confirmed diagnosis. And so she found 23% with confirmed diagnosis of BPD and 46% having treats of BPD. She also looked at what are the particularity that those mothers exhibit. So she found that infant cries was particularly distressing. For any mothers, when the cry is prolonged and when it's a prolonged time and the mom is feeling some anxiety or depressive symptoms, it can be triggering. But for mothers with borderline personality disorder and treats, it becomes distressing. Distressing to the point that it can lead to dissociation or like hostility towards the child or withdrawing as well. And they also having difficulty to bond with the child. With trial and error, she decided to develop a protocol for inpatient admission. So when they have new patient, they always look at if they have the diagnosis, and if yes, they start a protocol, which meaning like they start doing some psychoeducation and doing as well as specific interventions such as mindfulness and distress tolerance tools. And once those patients are discharged, they're eligible to benefit from mother-infant DBT in the community. She also was able to prove the need to incorporate BPD in the mental health guideline in Australia in 2017. COPE is actually the guideline, or the web has a very beautiful website, COPE, that is interesting to look for any mental health professional working with mothers. Now let's look at objective number 2. We're going to look at the clinical presentation that these mother has during pregnancy and the postpartum period. So during pregnancy, For those working in like obstetrical care, it's important to know that mothers with BPD have higher risk of obstetrical complication. So preterm labor, threatened preterm labor, gestational hypertension and preeclampsia, as well as their babies have increased risk of neonatal negative outcomes, such as low birth weight, lower APGAR scores, and NICU admission. And these risks can be in part explained by polypharmacy and obesity, but not to all the risks. And these risks are also very significant. If we just look at the gestational hypertension, it's a risk of 6 times more. If we now look at the mental health outcome, those mothers often have increased anxiety. Mothers with BPD, unfortunately, often have difficult experience as a child with their caregivers. Some have experienced abuse and neglect, and don't have necessarily had the chance to have a model of parent who were present for them, who was emotionally available. And so becoming a parent without having those model and those, it's really hard. It's very anxiety provoking. It also, their BPD symptoms can also increase. So main one being the mood roller coaster of emotions, the higher impulsivity and more conflict with other people at a period of time when you need having people around you for support. They also often may have difficulty to bond with the baby. Some discomfort and negative feelings about baby movement. There is also a high proportion of them who have unplanned pregnancies and very ambivalent or negative feelings about the pregnancy. There's higher risk as well of admission during pregnancy. And there's some of them that are very happy, never been as happy in their life because they don't feel alone. They don't feel empty anymore. They are with someone, always with them, and they feel complete for the first time in their life until delivery happened. And in very rare case, there is, and those happen in very severe form of BPD, as well as it happen in severe form of schizophrenia, there can be denial of pregnancy. So having a positive, despite having positive pregnancy tests, they still believe that they don't have a child. And even, and the very impressive things about denial of pregnancy is that as long as the denial of pregnancy stays, the body does not show much until they start believing that they have a child. The pregnancy is very important in kind of starting to think, not only like to change the body to prepare for the child, but also to start thinking about what kind of parent that I want to be, what kind of relationship I want to have with my child, what are the things that I did like or did not like as a child with my parents. For delivery, unfortunately, a lot of mothers, women with BPD experience sexual abuse in their past. And so delivery can be quite triggering. There is more risk of experiencing traumatic birth, even though the birth can be very smooth and uncomplicated. It can, just the process of the delivery can be very intrusive and triggering. And then they have more risk of experiencing anxiety, flashback, dissociation during the delivery. And they also have more risk of, when they experience sexual abuse, of that the breastfeeding can be very triggering for them. It can make them feel very uncomfortable. They can experience disgust, anxiety, flashback, and dissociation. Something that we need to be aware of it. And sometimes just naming the possibility that it can happen can be very validating if it happened again. And so they can be more able to like feeling less shame in talking about it in the future if it happens. And during the first year of life, they also have or at higher risk of experiencing postpartum depression. First of all, from a biological point of view, they are more at risk of postpartum depression. From a psychological point of view, they also are often have a very difficult relationship with their parents, especially their mother, which is a big risk factor for postpartum depression. And they often have history of childhood trauma, which can be reactivated by being a parent and within their relationship with their child. They are also at risk of having postpartum depression from a social point of view because they often have very conflictual relationship with others and also poor social support. When mothers have the comorbidity of BPD and postpartum depression, they are more at risk of being admitted in psychiatry during the postpartum period, more at risk as well to have suicidal attempt, and also their stay in hospital is longer than if they don't have the disorder and even if they had another personality disorder. They're also more at risk of, unfortunately, abuse or neglect their child. Something important to notice is that if when we have a positive Edinburgh, which is a scale to evaluate postpartum depression and depression during the pregnancy, it can mean different things. It can mean, that's why we need a formal psychiatric evaluation when we have a positive test. And so if it can mean depression, it can mean an anxiety disorder, but it can also mean a diagnosis of BPD or BPD treats, which make this period of time very difficult. Also, as we discussed previously, babies' cries are not only provoking anxiety, but are distressing to the point of dissociation for some women. We talk also about breastfeeding, which can be also provoking symptoms for them, PTSD symptoms, and also during that period of time in the postpartum when mother have a big change in their life, right? A lot of new things to adapt, does not sleep, have the big drop of hormones, and have a baby who always need them. It's very triggering, and that present with an increase of BPD symptoms such as the mood dysregulation, the impulsivity, and the difficulty, more conflict with other people. Also present as an increased substance use disorder, which has been, for some of them, a coping mechanism for so many years. Increased admission for postpartum depression, and in more severe case, I've seen, and it's been described, regression into childhood behavior. So does not want to have any contact with the child, just want to be left alone in their bed, and even exhibit posture of a child, a baby, and wanting other people to feed them. So really regress in that child baby state. We'll come back in the dissociation and about dissociation and baby cries. So baby cries because they want to express to us a need, right? When it's prolonged, it can provoke some anxiety and some frustration from mothers. But for mothers with BPD, it's particularly triggering. It may reactivate some painful emotions of that are very unconscious, and that goes back to their relationship with their parents, and unresolved emotions regarding to the trauma at that time, trauma from the past in their relationship with their parents. And it's so distressing that the brain just shut down and goes in a dissociation mode, which for the baby then is very frightening. And when it's repeated over and over, leading to baby dissociating, and over time leading to disorganized attachment and transmission and intergenerational trauma if we don't intervene. More subtle forms of BPD, a very beautiful article written by Ansfed William that we discussed before, and the other pioneer in the field of perinatal BPD, Gisèle Appert in France, about what are the subtle forms of BPD. So those mothers that we'll see more in family doctor's office. Those moms that before the arrival of their child, they were able to function relatively well. And unless like some stressors and some BPD symptoms, some symptoms when stressor, but when the child arrives, the child that always needs to be with their moms, that they need to answer when they cries, that they need to be always there, it can be quite distressing. And they will often come with distress and talking about difficulty with feeding, sleeping, and settling. There is a beautiful article written in Australia about the service of consultation liaison, a more specialized service of consultation liaison for perinatal period. So consultation liaison is a psychiatric services that is on medical floor. So on a non-psychiatric unit. And what they looked at is that the prevalence is particularly high of BPD, people of mothers with BPD, and that those have BPD treats. They also noticed that there is a high likelihood of those mothers to have involvement of child services. They identified then the mothers with BPD as high-risk caregivers. There is also when the child starts to be like all the senses of the child seems to be more developed, and they started to around 5 months notice that they're separated from mom. Then it can be quite anxiety provoking for mothers with BPD, because it triggered the fear of being abandoned, and any step towards the separation and individuation of the child, such as when baby crawls, when baby walks, explore, start daycare, it can be quite anxiety provoking, and you see an increase of the BPD symptoms. Also, when the child starts to have the temper tantrum. So mothers with BPD already have difficulty regulating their emotions. So having a child that has difficulty, then because it's at that time their brain is in full developmental mode, with the emotional brain being overactive, it's very triggering for them to see their child in that high emotional state. It can provoke for them brain shutdown with dissociation. It can also provoke for them impulsive, aggressive act towards the child, but also to avoid seeing the child in distress and being distressed themselves. They may minimize the limits that they give to the child in detriment of the child's development. Now looking at the impact on the mothers and child relationship and the child development. So for mothers with BPD, what we see is that they experience a higher level of parenting stress, less feeling of being competent, less rewarding in the parenting role, and as well as they have lack of support. If we look at the challenge they experience throughout the age, we see that overall they're so affected by their emotions and reactivity of their emotions that they're not able to be as emotionally available to their children. They also have difficulty placing limits. They also have difficulty also understanding the expectation, the developmental stage of the child. They see it more as what they would expect of an adult sometimes. And with the infant, what we will see is that they will be so concentrated in their emotional state that they will be less sensitive to the child. And when the child will be in distress, it can bring them to fearing fear and disorientation, dissociation, which will lead more risk of disorganized attachment. They are also more at risk of being intrusive and negative in terms of their affect, as opposed to healthy parents or more depressed parents. They're also more at risk of being oscillating between being with their child hostile and controlling, and being passive and withdrawn. They also have difficulty in reading the cues of their child and difficulty and they're less structuring in their interaction with their child. When we look at the toddler and preschool age, they have difficulty with the developing needs of their child for independence because it triggered their fear of abandonment. They also have difficulty saying no and to place limits. In the school age, they are very inconsistent in discipline and difficulty being able to maintain a safe and stable environment. Then, for adolescents, they tend to be either very lax and oscillating as well to control through guilt, overprotection. There's a lot of role reversal that we can see with the child being the one that help regulate the emotion of the parent, as well as difficulty adapting to the adolescent wanting his own identity. And if we look now at the outcome for babies, what we see is that we can see early sign of disorganized attachment. So disorganized attachment, we can see it in study, and this beautiful video is a video that talk about the still face experiment. It's a way that we can evaluate in lab disorganized attachment. So what is the still face experiment is that we ask a mom and a child together to interact normally. Then we'll ask the mom to display a still face. So no emotional, no facial reaction. And then for about 2 minutes. And then to go back to interacting with the child. So the child that is used to having interaction response for the mom will try as much as possible to kind of interact with mom with voice, with movement, with posture, and then at some point will kind of stop and become a bit disorganized. But for mothers with BPD, the parents, they are more used to have still face, unfortunately. And so the child will more rapidly days away, have a very disoriented look, and look away, and when come asking back for the moms to interact with the child, it may not necessarily be present again. And the outcome for baby is over time, as those still phase, those difficulty in interacting with the child are apparent, then there's higher risk of disorganized attachment, unless there's something that is done for those vulnerable diets. And so there's the development of disorganized attachment. It's when the figure of attachment, the parent, which is supposed to be the secure and safe person, is rather very provoke frightened. It provokes a lot of fear. And so for the child, it's in their interaction with other people, when they have distress, they want to approach because their attachment is triggered, but they feel fear, and so they withdraw, and they want to be with other people, and they're very dependent, but it scares them, so they avoid, and they develop a very negative view of themselves as well. For preschool child, they look at what their play. They ask them to play mother and child relationship, and what they see is a lot of role reversal, with the child being acting as parent, regulating the emotions of the parent, and the parent being very emotional and needed that assistance. They also ask them to make some stories about the relationship between child and parent, and they would see a lot of more negative relationship, and also that the child see themselves as negative and shameful. They also would observe more emotional and behavior problems with these children. And for school age, a lot more emotional and behavioral problems, difficulty with school, and also difficulty in social adaptation, making friends, also maintaining friendship as well. For adolescents, then we see the beginning of BPD symptoms: suicidal attempt, self-harm, emotional dysregulation. In summary, what we see in prevalence that is relatively high, of 40% of perinatal BPD in perinatal clinical samples. We also see, and we discussed, that there is increased risk for those mothers during pregnancy, for those children at birth. They have they experience more parental stress, and there's more negative outcomes in terms of mental health for the mothers, but also for the children. And there's more risk as well of abuse and neglect if we don't intervene. And there's very little study, and those studies are limited in their design, and we lack those very good study, longitudinal study that will help us to know, permit to give us information about when do we need to intervene, what do we need to look for in terms of symptoms, and how do we need to intervene. And so I decided to form a beautiful team to work on a study, a longitudinal study, to better understand mothers with BPD and their children. So a study from pregnancy to the age 6, which is those years are so important for the development of the child and the attachment relationship as well. So it's a 7 years study. And the team is composed of an adult psychiatrist, an obstetrician, Dr. Gravel, a professor in psychology, Dr. Bureau, who has an experience in longitudinal study, my wonderful co-worker who is co-therapist with me in perinatal groups, Tammy Desforges, and Dr. Matheson, who's a child and adolescent psychiatrist working with 0 to 6 children. The inclusion criteria is women, age 18 years and above, having having a diagnosis criteria according to DSM of BPD, so a 5 out of 9 in the criteria, and being pregnant up to maximum 3 months postpartum at the start of the study. The exclusion criteria are because we want to avoid having confronting factors that will make the result not difficult to read. Those are comorbid psychotic disorder, comorbid bipolar disorder, and comorbid antisocial personality disorder. And what we aim to look at. So we want to look at the evolution of the mother's BPD symptoms during pregnancy and the first 6 years of life of the child. We also want to look at the impact of those symptoms on the physical and the mental health of the mother, as well as the relationship with their child and the child mental health. We want to look at what are the confounding factors, so contributing factor that may explain the association between the BPD symptoms and the outcome that the mom, the child, and the relationship. We'll look at measure for the moms, the child, the mother, and the child relationship, and the other parents. And we'll use questionnaires, interview with the patient, with the moms, as well as observational measure of the interaction with the child, and physiological measure looking at the oxytocin and the pulse of the mother. There is a compensation for mothers and for the other parent. And you can, for some reason, it stopped sharing. So you can, sorry, just gonna go back here, go back on your sharing and, okay, so we'll go back here then. Doesn't work for some reason. If you have any question about the study, or if you want to send the contact authorization of a patient, then you can email this email of the study or send a note to fax. In conclusion, what I want to say is that mothers with BPD and their children suffer a lot if we don't intervene. And so often, most often is that what happened is that we see these children in child and adolescent psychiatry, or we see these children later on when they're patient in psychiatry. Can we do it differently? Probably, but and a lot of those of mothers with BPD actually wants help, but sometimes they are fearful that their child will be removed. Sometimes they're ashamed of asking for help. And sometimes they don't know where to look for help. And there is very few services that are available. And why there is very few services available? Because a lot of persons don't know how to intervene with those high-risk caregivers, with those vulnerable dyad. So we need to do things differently and look at how can we help them. So I want to thank you all. And if you have any questions, I'm here to answer them.
What an amazing presentation, Valerie. That was an excellent overview of the evidence that we do have. And obviously, we now hear the importance of this longitudinal study that you're embarking. We need to understand more about how we can support the mother-baby dyad. We do have a couple questions that came through during your presentation. Maybe we can stop sharing the slide, unless just a second, maybe slide 16. There's a question about DBT. And this has to do with the mother-infant dyad on discharge in the Australian study. Yeah. So they wanted to ask more about DBT. So what is that, and what does that look like? Do we have that here in Canada?
So DBT is one of the gold standard therapy for patients with borderline personality disorder. So it's a therapy that will help the moms. There's 4 modules. One is about mindfulness, one is about distress tolerance, emotional regulation, and as well interpersonal relationship. So we have DBT for patients with borderline personality disorder. There's some programs of DBT for parents as well that exist in Quebec, and we also tried that program at Montfort. We did not find it as helpful. And so we kind of started a program here at Montfort it's called Reconnect, and it with one of the skills of a DBT, which is mindfulness. So being fully present in the moment to kind of acknowledge what is the emotions you're feeling, physical sensation, and everything. And as well as a bit of emotional recognition and distress tolerance skills, but more about mindfulness. So looking at kind of what is the in the relationship with the children. So what the behavior of the child or the reaction of the child, what was the intention of it? And looking also the mindfulness about the mother and her past as well. But so for borderline personality disorder, both DBT and mentalization are the gold standard therapy. And when you look around the world, you'll see that both therapies are used for mothers with BPD at different places around the world. And mostly people are going towards more mentalization approach. That works better.
And to be clear, when you say DBT, it's dialectical behavioral therapy, right? Yep. Okay, so I'll just put that in the chat. Thank you so much. And I think you've already started to answer the next question about the treatments for the child and the baby. So you talked about what the parent would do in terms of the mindfulness and awareness. So what about the baby and the child side of stuff with a parent with the borderline personality disorder?
So one thing that we can start from when the mother is pregnant to like when the child is alive during the early months is doing like dose therapy with the child being present, so that we can kind of look with doing some modeling and also interacting with showing some of the interaction, what it means with the mother. So it's both during the group therapy, then in the individual session, when we're able to, when we have a good relationship with the patient, intervene and help the mothers in the interaction with their child.
Excellent. Thank you so much. And you have amazing collaborators as well with your research team. If we go back to that slide, so these are some familiar faces that people probably are familiar with. Yeah, this amazing team that you have here. So there's a question that came in about what tools will be used to assess the quality of the parent-child relationship. So this is someone who works in public health. So what would public health nurses be able to assess when they're with families?
So there is a beautiful observation tool called Ambience Brief. That is a tool that we use to measure atypical maternal behavior that will lead to disorganized attachment. So that's one of the tools, and it required a specific training to be reliable, and we do have that. There is also going to be measure of attachment with a scale during the pregnancy, as well as a measure, and it's the scale is MAAS, and there's going to be as well a measure of attachment in the postpartum with the scale postpartum bonding questionnaire, so PBQ.
Awesome. I was just doing a quick search for the Ambiance tool, so that's excellent. I'm just thinking logistically here, with borderline personality disorder being more common than postpartum depression. Can you comment about the screening tools that we use during perinatal care? So is the EPDS, the Edinburgh Postnatal Depression Scale, sufficient as for the general healthcare provider?
So I think that so the Edinburgh will give you if there is any depressive symptoms, but then you'll need a more formal evaluation to see what are those depressive symptoms. They can have different diagnoses associated with that. So I think that what has been done in Australia and kind of looking at screening every woman with in the perinatal during pregnancy and postpartum is very useful. And it's something that I think eventually will be great to do as well, because there's a lot of women that are not diagnosed and they're mistaken with maybe sometimes having postpartum depression, and not being diagnosed with the treats makes us give treatments that are not necessarily as effective, and the symptoms can pursue over time and can lead to some difficulty in relationship with others. So I would suggest to there's one scale that is relatively easy to use. It's either the McLean scale for borderline personality disorder. That can be, it is looking at the criteria of BPD. So if you could just start with when you have a patient, a mother's with having some depressive and anxious symptoms or emotional distress, just screen her for if she does have BPD symptoms. That would be a great start.
Thank you so much. And I'm thinking maybe we can ask Beth and Dr. Jasmine Gandhi about putting some of those screening tools on the ASMASI website in terms of just increasing our awareness of screening tools that are available. We're going to, not Catherine, Charlotte, maybe you can launch the poll as we finish the last couple questions here. One's about cognitive behavioral therapy. Does that help as well for patients and clients with BPD?
Behavioral therapy?
Cognitive behavioral therapy, one-on-one?
And because borderline personality disorder is a relational disorder, groups are more useful for those mothers and for those patients as well. But CBT is has not been indicated to be very useful for people with borderline personality disorder. It's the three therapy that are recognized to be the most helpful, or dialectic behavioral therapy, mentalization-based therapy, and as well as good psychiatric management.
Awesome, thank you so much. One final question about recommendations for an approach to a mom who isn't interested in engaging in the dialectical behavior therapy or therapy for herself, or when there's no funding for therapy. or the support to be able to attend therapy. So, what can we do in that situation?
So, I mean, sometimes the only way is to be patient and to try to be supportive to that and build that relationship with the parents, and eventually starting to give them some tools to kind of recognize their emotions and to tolerate their distress. And you can also, so in terms of having the support there, so the group we have at Montfort is OID-based. So that's something very useful. They can bring their babies as well. So that's a way. So
Awesome.
just starting to build a relationship, and over time hope that you're gonna be able to build a strong enough relationship to offer more. And if not, then the child will probably have help when they're starting school.
Yeah,
Hopefully.
they'll be identified a little bit later in school. Well, this has been an amazing webinar, and the poll, I don't know, Valerie, if you can see this right now, but there's definitely movement in terms of people's level of confidence, in terms of identifying the clinical presentation, in terms of supporting patients and clients. And, we have almost 2/3 of the group feeling better able to recognize the potential impact on the mother-child relationship. So this has been an amazing session. Charlotte's going to put a link to the evaluation. So we appreciate your feedback and suggestions for future webinars. And I do want to mention that we have our ASMASI webinar series is continuing in September. So September 16th, the focus is going to be on depression and bipolar disorder. And then Valerie is actually going to do the same presentation in French on Friday, September 20th. So we'll be sending out those registration links shortly. But we hope to continue on the conversation so that we're all continuing to increase our knowledge and finding ways to identify mental health disorders and figure out support. So look at the CMNRP website page or the ASMASI webinar page under education. There's also the annual course that's coming up October 18th. The registration is now open for those who want to set aside that date. It's going to be happening in Ottawa on Friday, October 18th. So Valerie, thank you so much for sharing your expertise with all of us here today. We really, really appreciate the information that we learned and your time in sharing this. So we wish you great success with your study recruitment, and we hope everyone has a great summer.
Thank you very much. Have a good day.